Hello, I'm Jess. I'm the team lead on the EF. So we're just going to talk about discharge planning. So we'll start from the complete front door. So a patient will come in through A&E. They will generally be seen by someone on A&E or CDU. If the patient can go home from there, they will do. Sometimes they then get admitted to the emergency floor, and the emergency floor has a stay up to 3 days. So it's quite a quick turnover. The services that we have available for the emergency floor are responsive services. Responsive services is a community team made up of physios, OTs, healthcare assistants, and they do have access to social work as well. So if you feel as though a patient needs 2 of the disciplines, so that could be a package of care and physio, package of care and OT, then you could refer on to responsive services. We have a coordinator who is a nurse working on the emergency floor. So if you feel as though this is the right way to go, have a talk with her, discussion, and she will make the referral for you. And that's on the phone via one call. The next service that is available as well is if you think that someone just needs a package of care, or you think they might need some OT input, so that might be for an environment assessment in their own environment, then we can refer to CRS, which is Community Reablement Service, and that's through social work. Again, we have access to social work via the bleep, which is 1350, and we also have access to social work during our MDTs that happen every day at 11, so we can discuss that with them there. Again, we basically just tell them how many times a day they need the package of care, and what if they do need OT input. We normally write this up on the board as well throughout zone C and D, and so that it's clear for everyone. The other services that we also use are rehab beds. So to make a referral to community rehab bed is the new rehab bed form, but they will just be, you just give them to the ward clerk, filled out, and they will send them off for you. So a lot of all these services that you need to refer to is as long as you do the paperwork or make the decision as to what these patients need, a lot of the referrals are already done for you, so you don't need to do that. If you document it clearly on the boards and throughout your notes, then it will all happen. If needed, that you find that some patients might need, they already have a QDS package of care, so that's going in 4 times a day, that's the maximum they can have, and you feel as though that their mobility has got worse or they're just not managing at home, we can ask social work to assess for residential home or nursing home if required from the emergency floor as well. A lot of these patients will tend to go up onto the ward from there to have further assessments, but what's quite good to do is to ask the nursing staff to do some activity and night logs for these patients, as then it sort of quickens up the way that patients then get out of hospital, so there's just less days within this hospital environment. A sort of last service that we could use is dementia crisis service. So dementia crisis service is a service that's available just from the emergency floor. Again, they work 7 days a week, but with this service the patient must come in because of their dementia. They can't have an infection, for example a UTI. They have to have literally come in, maybe they were just wandering, and they would benefit from having the specialist dementia crisis service involvement. Again, this team is another phone call which is done by the coordinator. We can start doing them as well if needed, but the best route to go down is through the coordinator, and they can also offer a package of care for the patient, emergency respite if needed, and they can have an OT assessment as well. So if those patients that you see on the emergency floor can go home with one of these services, they will do quite quickly. The other sort of services you might want to get involved in to get these patients home is take home and settle, where the patient literally gets picked up via a car and they literally take the patient home and do what it says, take home and settle them in. They will get them their sort of a little snack if they need it. They'll literally change the bed linen if possible, and if there are any further problems, they can then refer to social work from the community. So that's a really good service to sort of make use of. The other one is home from hospital. So this sort of service is only available if the patient lives alone, and sometimes you get those patients that you're a little bit worried about because they're going home alone and they might not kind of meet that requirement of needing a package of care or needing responsive services, but they just need that sort of little check-in. So home from hospital is a great one. There's the leaflets all around on the emergency floor to do this. It's another phone call. You don't have to do it, the coordinator can do it, and they will literally go into the patient's home and make them a light snack, go and pick up their prescriptions, take them for a walk outside, so that you can kind of get that small bit of physio input from there as well. The other bits to sort of consider are the transport. So we just need to check, has the patient got any steps to get into the property? And if so, how many? And if they live in a first floor flat with no lift, do the stairs go straight up or do they go straight up and round the corner? These are the things that the ward clerk needs to know. And if they need an assessment from the ambulance crew. So they're good things to just check with these patients to get them out the door quicker, and just checking if they do have a key safe, which you'd normally do in your assessment anyway, and that you've got the number or they've got a key to their property. So that's pretty much from the emergency floor as to the options that we have there. If patients, you're thinking actually these patients are a heavy assistance of 2 and they're way off their mobility sort of baseline, then those patients will then be, you'd recommend those patients going up onto a ward, and this is where the services from the ward will start.
Hi, I'm Dawn. I'm the Ops Manager for Occupational Therapy. So just spoke to you earlier about the emergency floor and the discharge processes from the emergency floor. Once the patients go to the ward, then it's a slightly different process. Things have changed, evolved over the last few weeks as we've had more and more COVID patients coming into the hospital, and we now use a discharge hub for all of our discharges that require care, equipment, TTOs, etc. once they're discharged from hospital. So the process is simplified for all of us. You would start your therapy on the wards, you establish what your patient's needs are, and you complete a referral to the discharge hub. It's a 2-page form and it has a huge amount of information on it that you're required to get from a therapy point of view. The nurses will fill in the bits from the demographics, the medications the patient might be taking, any of their medical status, etc. And you are responsible for filling the bit in about the therapy needs and a little bit about the home environment and what you anticipate that patient will need when they leave the hospital. So for instance, if somebody is safe to be left between care calls, but they need assistance with washing and dressing and getting in and out of bed, then you may put in a BD package of care, so once in the morning, once in the evening. Or they might be fine in the evenings and you just need that care once a day, plus therapies to help them regain that independence. So the discharge hub will receive that form, they will triage it to see what services are available, and they will send to the most appropriate service to provide that service for the patient. So it could be that if your patient needs, for example, a 4 times a day care call coming in to help them with all their transfers, their toileting needs, their meals, etc., it might be that that is not available at the moment and it has to be provided within an interim bed. So just because you say that patient needs this level of care at home, it doesn't mean that that patient will definitely go home. In these unusual circumstances, it might be that the patient goes to an interim bed whilst waiting for that care to start at home. At the moment, the impetus is getting people out of hospital. Where they go to when they go out of hospital could be variable depending on the services available in their area. So the important for you as therapists is to remember to fill in that discharge hub referral form as soon as that patient is ready, so medically ready to leave the hospital.